model of providing primary eye care. And the intention of this is to achieve universal eye health. Of providing primary eye care. So I'm getting a echo and a delay. I'm not sure why. So before I move ahead, I just wanted all of us to be on the same page on what we mean by universal health. Now, it's got three components. This may be familiar to some of you. One is about making sure that everyone who has got that health need is covered in terms of access. And then once they access the care is comprehensive in the sense it is covering all aspects of that condition, resulting in resolution. And then in doing that, we are not bankrupting the person, that is, it's financially affordable. So these are the three dimensions or definition of what is meant by universal health coverage. And I'm applying this concept to the universal eye health. And again, why is this important? Because it's in the context of our purpose, which is eliminating needless blindness. It requires reaching everyone in need of eye care. So which means that when we achieve universal eye health coverage, we would have reached everyone, which would move us towards our purpose of eliminating needless blindness. And that is how all of this fits in. So right from the beginning, the focus was on reaching the unreached. What this means is that in the hospital, people come and seek for care. And then you provide treatment, and you could make it affordable, give it for free, whatever it is. But then this would achieve the goal of serving everyone if everyone was coming to the hospital. And all of us know that doesn't happen, and happens far less when it is an elective condition like eye care. Most of eye care conditions are elective. Some are emergency, but things like cataract, refractive error are all elective procedures. So the only armament that we had was to conduct eye camps to reach these people. And then these eye camps were conducted by us in very large numbers. And this is the number for the last year, 23-24, where over 3,000 camps were conducted, close to 6 lakh patients were screened, and 115,000 plus patients got cataract surgery. These are very high by any benchmark. And yet we ask this question because of our commitment to the purpose, whether the eye camps are good enough to achieve our goal of serving everyone. So we did a formal study to assess this. And what the study showed was, what we did was we identified 50 communities. We organized camps around them. It was blinded to the communities and to our people so that there is no bias. Then we went back to those 50 communities and enumerated everyone who felt they had an eye care problem, because they are the ones who should have come to an eye camp. But then of that group, only 7% had actually shown up at the eye camp. So this was very clear that this approach was not good enough. And then once the results were in, we also were able to recognize that us going one day in a year to a community, largely at our convenience on a weekend when we can go there, may not be convenient for every single person to come and seek care. So logical solution was that we should have a permanent facility in each area which is served by an eye camp. An eye camp typically draws people from up to a 10-kilometer radius. So can we have a permanent facility which can be there and serve that community? So that was the conceptual solution. But then immediately a lot of challenges popped up. Now, one is how would we staff this center? Because obviously we don't have enough ophthalmologists to do this. And also ophthalmologists would be very unwilling to go and sit in a rural remote area. The next question was, if you're going to post someone who is not an ophthalmologist, would the quality suffer? Then again, the big elephant in the room is that would this be viable? Now, how would we manage these small centers? Now, will it be financially viable? Will it run smoothly? All these questions came up. But then we decided to kind of pursue that. And we also were dictated by some guiding principles. Now, one, if you want to provide eye care to everyone through these permanent facilities, then our thinking has got to be denominator or community need focused, so that we are able to actually monitor and provide eye care to everyone. The access should be affordable with minimum effort, in the sense they shouldn't need to spend too much money to come to that place. And once they are there, they should get a comprehensive quality eye examination. That is, a diagnosis should be as comprehensive and accurate as feasible. And then once we have a diagnosis and a treatment plan, we have to enable what we're calling as closing the care loop. Now, that is making sure that the patient's eye condition is fully resolved. And then all of this has to happen with some level of operational excellence. So these were the broad guiding principles that we kind of put in place. And then we defined the scope of services. Now, what is listed as various conditions here broadly covers, I would say, over 90% of all of eye care. Cataract, refractive error being the most common one, children's eye care needs, diabetic retinopathy, and so on. And then we said that this center should be able to do case detection for all these cases. For some of this, we may require some technology help, like to detect diabetic retinopathy, you would require imaging system and some technologies to read those images. Similarly for glaucoma. For certain conditions like refractive error, we should be able to provide the curative service, that is giving them a glass prescription and even glasses. For things like cornea, trachoma, which is now eliminated, also we should be able to provide at least the first line of treatment. And the certain conditions can be prevented, which again should be part of the services offered. And then for almost all cases, as appropriate, there should be a referral and also an accountable follow-up mechanism to ensure compliance. So this we defined as the scope of services at the primary eye care level. And then we also defined for us what should be the scale of service in each center. Now, typically in our country, given our population density, for about 10 to 12 kilometer radius, we'll be covering a population of about 1,100,000 people. So in our very crude or rule of thumb estimate, is that roughly 25% of them will require some form of eye care. This is derived from the age profile of our country, where more than 25% of the population is above 40 years of age. And all of them will require near vision glasses, and some of the younger ones also will require. So given that, we estimated that 25% or 25,000 in the 1 lakh would require some form of eye care at some point of time. Cataract surgeries, again, we estimate that for every million population, we need to do, somebody's doodling. I hope they. So based on the target of 10,000 surgeries per million, we would have about 1,000 surgeries for every 1 lakh people to be done on an annual basis. And similarly, if you recognize that 20% of the people would require glasses, and then they would replace it once in 5 years, we should be providing 4,000 glasses per year, and so on. So I won't go into all the details. This is basically, we brought in a denominator-oriented thinking. So this we kept as the scorecard in each of our primary eye care centers, what we call as vision centers. Then when it came to selecting where do we locate these centers, one cardinal rule was that it should be in a place where there is no eye care service in the vicinity. Can people kindly mute? That is, there is no eye care service within 10 to 15 kilometers. And we wanted it to be located in a small rural town, maybe around 10 to 15,000 population, so that there is reasonably good connectivity that's already there. So that access becomes practical. And it should be within about, say, 40, 50 kilometers from the base hospital, so that the referral compliance can be healthy. And then wherever possible, we wanted to have community involvement in establishing the centers as well as in assisting in its running. So in terms of the actual facility, it is always in a rented building, roughly about 500 to 600 square foot, which we're able to, depending upon the place that we get, we partition it into a place for receiving the patients and for consultation. And if there's an extra space available, we will use it for storage and other services. And then also toilet facilities, both for the staff and the patients. And then we also standardize the equipment, keeping in mind the scope of services. What are all the diagnostics we have to do? So based on that, we standardize the equipment and the furniture and all of that stuff. So roughly, we can set up a vision center for about anywhere between 10 lakhs to 20 lakhs, depending upon the brand of the equipment that one buys, and then what all equipment we put in, as we start, and the furniture and some money for refurbishing the rented apartment. And then, like the title said, we introduced technology from day one, and I'll tell you why this was important. So the first center started in 2004. So right from the beginning, we introduced electronic medical record in the local cloud, in our own servers, so that there can be real-time collaboration and real-time telemedicine. So this is how we address the concern around quality. So if the medical information is available both to the doctor and the technician with the patient in real time as they are collecting the data, and if they can communicate in real time using telemedicine, the diagnosis to a great extent would be very similar to what would happen if the patient actually visited the hospital. So that's the thing, which we also demonstrated through some research studies later on. And then down the line, in the last 10 years, we've also added cloud-based artificial intelligence for interpreting retinal images. And about 10 years back, we integrated the entire EMR in the vision centers with the hospital EMR, so that the entire compliance tracking and management becomes a lot more efficient. So all of this happened, like I said, in the year 2004, when there was no internet or broadband in the rural areas. Even a big city like Madurai barely had usable internet, a very slow speed. So in order to get telemedicine going, it required a much higher broadband, higher bandwidth for connectivity. So we put up our own towers and used Wi-Fi, which is an open spectrum, to go long distances. We worked with some researchers from University of Berkeley, and then we were able to achieve 4 to 6 Mbps bandwidth, which that time was something phenomenal. And then we could make this go up to 50 to 80 kilometers, so which was quite an achievement those days. And then in terms of staffing, we have 2 people who are posted in each vision center, 1 person to register the patient, handle the consulting fees, the glasses, medicine, and then do that coordination work. The other person is a technician whose skill set would be like that of a very well-trained optometrist. So they'll be able to conduct all the required eye examinations, from measuring vision to refraction to doing a slit lamp exam, looking into the retina, and so on. And then once all of this is in place, we have a formal inauguration where there is a lot of community involvement. As you can see in these pictures, we use a local dignitary for inaugurating the facility, and they are explained about the function. So this engagement really helps in sustaining the vision center from multiple perspectives. So I'll run a brief video to demonstrate how this works.
It plays well, Tulsi.
Okay. Yeah. So a patient walks into the vision center, pays a consulting fee of 20 rupees, and they are registered online. So the only paper that we generate are things like this. Then the technician does a detailed examination. Here she is doing the refraction. We also use this to do a blood pressure check and also check for diabetes. Then the patient gets a detailed eye examination, dilation if required. We check for intraocular pressure. Then all of these findings are entered into the medical record. And here she is examining taking image of the retina using a specialized camera. And then everything is uploaded into the medical record. And then the doctor in the other end reviews the chart, listens to the technician, talks to the patient, decides on the diagnosis, and then the prescription is given, and based on that, in this instance, it is a pair of glasses that was required, which is made available right there itself. So you can visualize this patient journey, and then you would also seen that the patient actually came on their own. Which in a larger hospital, this lady is unlikely to have come by herself. Someone would have come with them. So this is how the vision center works. Then I will spend a few minutes on how do we generate demand for these centers. Making it available is one, and then when it functions well through word of mouth, it propagates. But we also need to do something proactive. So in the early days of any vision center, we would, depending on the center, we might do door-to-door screening to identify people with refractive error and other things and refer them to the vision center. Screen the school children in the service area of the center, health education, which I'll show a few more slides, and then training volunteers to promote eye care. So since this 100 days working program came in, MN GRES, now we would go to those groups that typically tend to be slightly older people, who are in 40, 50 plus. Now we have health education programs for them, and then even do a very simple vision screening, and then give them referral cards to go to the vision center. And then people who are sent through this process, we usually waive the consultation fee for the first visit. And that we're able to increase the demand to these centers. So if you look at performance over the years, we have now established 118 vision centers as of today. And then last year we handled more than 10 lakh outpatient visits through these centers, which means on an average we see between 3,000 to 4,000 patients every day through these centers, averaging about 35 to 35 plus visits per vision center per day. So this is an important slide, because I had earlier shown that in the vision centers, our coverage of those who are in need, a very small subset of the population, was 7%, which translated to less than 0.25% of the population. Now here, these 117 centers are covering a population of 1.2 crores or 12 million. Out of them, we have seen 34 lakh unique patients, which translates to 28% of the population. So this is what is giving us a confidence that we are probably quite close to saying that this model is reaching everyone in need of eye care. This is the data for last year. Like I said earlier, we handled more than 10 lakh outpatient visits, from which we gave more than 1,17,000 eyeglasses were purchased, which represents a 75% compliance, which means another 30,000 odd did not buy the glasses because maybe they were happy with what they had or other reasons. About 43,000 people underwent cataract surgeries, with two-thirds of them accepted, a third of them did not get operated, or were unable to track the other thirds. Some of them could have gone to other providers, or they could have gone to an eye camp or otherwise. What was interesting was that of this 43,000 people referred to undergo cataract surgery, 1/3 of them preferred to pay for the services and get. In our hospital, in every branch, there is a paying section and a free section. The free side, they only have to pay 1,000 rupees, mainly for the consumables. So 2/3 opted to get it for free, while 1/3 were willing to pay for it. And about 60,000 people who were referred for more advanced conditions showed up at the hospital. So we're able to track every single patient to know whether they followed through or not. And then we do things to encourage them to go to the hospital if they've not followed up. So over the years, we have kept adding these vision centers. And then the number of patients that we see have been very steadily growing, as you can see. We started with very few vision centers in one center in 2004. Now we have 118 as of today, but this is as of March. The 2 years where we had a slump was something which all of us experienced during the COVID pandemic. And then there's also a very interesting trend in the daily attendance. We studied about 75 lakh outpatient visits that happened till the end of 2023. And we found that, and we looked at what was the footfall of a vision center in the first year of existence. So when we did the analysis, 104 centers had completed 1 year. So there, the average footfall during the year was 17. But as the centers became older, the number of footfalls kept increasing. It's like some ups and downs are there, probably because of COVID and other reasons. Now the older centers are all seeing closer to 40 patients a day. So this again reinforces the continued need for eye care in those communities, and the relevance of this model of working. So if you look at impact of this, one, there is universal access based on the evidence that I showed. And then universal access and local access also translates to early detection of conditions. And then there is a tremendous cost saving. We just did a very rough calculation of what if the patient from the vision center area had to come to the hospital. And very often, if a patient is coming from a rural town to hospital, there's always an attendant who comes. So which means in addition to transport and other costs, there is also lost wages, which we estimate to be total around 1,400 rupees per patient. This is excluding any payment to the hospital. But in the vision center, a similar patient would spend much less time, which means much less lost wages. Not every patient will have an attendant. If they're very young or very, very old, then somebody may come along. So we estimate that cost to be around 330 rupees, or saving about 1,000 rupees per patient or per visit. This is a kind of a financial impact that we have now, which translates to these centers are probably adding about 100 plus crores each year to those communities now by eliminating that much expense to seek eye care. And then bulk of the patients get their care completed locally. Only 15% get referred either for surgery or for more advanced diagnosis and care. So because of saving in transportation alone, there is a huge environmental impact. So for each year, we compute that we have saved about 63 million person miles of travel, which equates to a phenomenal amount of carbon emissions that are averted. And then this also offers a great learning, both for the doctors who see a variety of cases. They also learn how to talk to rural people, how to kind of relate to them, quick decision making. And then they're also able to follow up the cases through the vision centers. And then for the technicians who are at the center, again, there is a tremendous amount of learning. And then many of the people who visit our vision centers are very much appreciative of how skilled these technicians are. And very often they would say that, oh, they are even as good as our ophthalmologists or even better. And they also become very good in management, where they have to manage the whole center. And they're also very close to the community. So there are tremendous amounts of impact. And then looking at what makes this really work, I think it really starts with the commitment of the leadership. So we have to commit a lot of resources and support from the base hospital, like for teleconsultation. Like in our Madurai hospital, which manages 40 vision centers, we have 5 to 6 doctors constantly engaged in giving the telemedicine support. We need to have standby staff because people go on leave at the vision centers, and we can't. We don't like to close them so that the service is reliably available. And the entire supply chain, glasses, medicines, maintaining the instruments, equipment, all of that. Support for surgery referral management. And then we need to continually train these staff. And then we also need to monitor them on a regular basis. And then other thing that is helping is we function on all days of the week. No, so it's a very reliable, available service. 9 to 5, the center is open, and then involve in the community wherever we can. And then we also take responsibility for compliance. So we send out reminders, etc. And then we also constantly expand the scope of services. Now, for the last 3 or 4 years, we are now doing all the 1-month follow-up of cataract surgeries or the next day follow-up at the vision centers, and similarly follow-up for other advanced conditions like double retinopathy and glaucoma, mainly for stable conditions. And also now we're integrating systematically school eye health with the vision center population. And then these centers are also financially sustainable because the fees are very affordable, very transparent. And then because they have good outcomes of their condition being resolved, there's also a greater trust and willingness to pay. And then all this, we also take a lot of pains to understand the local needs of the community. Like, for example, if it is glasses, now we look at the kind of variety we have to place there, which the local people appreciate, its quality, now how much it will cost, now how quickly can we give these glasses to them. Now, if it is readers, they can straight away buy and go, like you saw in the video. If it is a prescription glass that has to be made, they would typically get it within 48 hours. So those kind of things encourages patients to continually come and also refer others to this thing. And then also it's important that we, when it comes to staffing, the staff who work there are those who are from that area. And many would be from that same village as well. And they get continuous training and they're empowered to take local decisions. So all of this leads to sustainability. And then monitoring, like I said earlier, there are weekly reviews and there are weekly classes for addressing both training and then for addressing whatever comes up with the during the monitoring process. So I'll skip this. This is too much of detail. And finally, in conclusion, we've also been proactive in scaling this beyond Aravind. Within India, we have 40 centers in Tripura. Chhattisgarh did piloting of 12 centers. Other than our centers, there are about 235 centers that came up through our initiative, some through the Rotary Foundation, and 30 plus by the government of Tamil Nadu. In Bangladesh, we have a national program where we are systematically covering the whole country with the help of the Bangladesh government. And we also run programs to other hospitals that are running mission centers in improving their performance and outcome. So in conclusion, I'll share a very brief video. In case the voice is not audible, don't bother because she's speaking in Bengali and there is a subtitle.
কিছু দেখেছেন যে প্রতি উপজেলার স্বাস্থ্য কমপ্লেক্সে যে কমিউনিটি ভিশন সেন্টার আমরা স্থাপন করছি সেগুলি কিন্তু সেই বেস হসপিটাল একটা রেখে আমরা টেলিকমিউনিকেশনের মাধ্যমে তাদের পরীক্ষা করা হচ্ছে এবং চিকিৎসা দেওয়া হচ্ছে। আর যে ক্ষেত্রে একটু মানে ধরেন অপারেশন বা কিছু লাগে সেটা তখন হাসপাতালে নিয়ে এসে তাদের করে দেওয়া হচ্ছে। আজকে ডিজিটাল বাংলাদেশ হয়েছে বলেই এই সুযোগটা আমরা তৈরি করতে পেরেছি। তাদেরকে আমি আন্তরিক ধন্যবাদ জানাই। আর বিশেষ করে ভারতের অরবিন্দ আই কেয়ার সেন্টার তারাও কিন্তু এগিয়ে এসেছেন এই বিষয়ে আমাদের যথাযথ পরামর্শ দিয়ে এই চিকিৎসা সেবা মানুষের দুর্গয়ে পৌঁছে দেওয়ার জন্য। কাজে সকলকে আমি আন্তরিক অভিনন্দন জানাচ্ছি এবং এর সঙ্গে আরো যারা ডাক্তার এবং অন্যান্য সহযোগীরা ছিলেন তাদেরকে আমি ধন্যবাদ জানাই যে আপনাদের পরামর্শেই কিন্তু আমরা এই কাজটা করতে সক্ষম হয়েছি। কাজে সেজন্য আপনাদের বিশেষভাবে আন্তরিক ধন্যবাদ জানাচ্ছি।
So with this, I'll conclude thanking the organizers for this opportunity and also dedicating this presentation to our founder, for whom this was very, very close to his heart, to make sure that everyone in need of eye care gets it. Thank you.
Thank you so much, sir, for this session. And it has been an eye-opener for us because we came to know that how much eye care now in today's thing, eye care is very important. With other like medical care, eye care is also very important, and people do neglect the eye care very much. And it has been seen in rural areas and all, they don't take care of their eyes a lot. But this has been an eye-opener for us, sir. So now I can go ahead with the questions. If anybody has any questions, please you can ask, sir, and you can get the clarification on the same, sir. Does anybody have any questions? Dr. Ravindra, would you like to say a few words on the session, sir?
Ravi, unmute. Ravi.
Yes, yeah, unmuted. No, yeah. Thanks for this opportunity to share this initiative from Aravind. Then, as you all know now, when we want to deliver eye care to the community, the way we have been doing it earlier was through the eye caps. And that has been the traditional for the last maybe like 50, 60 years. We have been doing it in that way. In that way, the eye care is available to the community at least at one point of time. And we also found, as Tulsi mentioned, only about 7 to 8% of the population only access the care of those who need that care. When you are able to have a center like this, as again shown by Tulsi, almost 100% of those who need eye care are able to access that. So that's a major impact. I don't think through any other means, we'll be able to reach those who need the eye care. And as these the technicians are get trained, they're able to even diagnose all complex diseases like papilledema, vein occlusion, vasculitis, retinitis, all of that. And there is another major area where this is really useful is taking care of minor ailments like a corneal foreign body. If somebody has got a corneal foreign body, if that center is not there, they have to travel 40, 50 kilometers to come to your hospital, get it done. Being there, right, they're able to get it done with very less effort. Not only they spend the less money, but the suffering they have to undergo is also maybe for that less than an hour. Otherwise, they may have to endure that for a day or two before they get really treated, provided they know where to go. That's again a challenge for the people in the rural area. And again, when there is a aberration, they get a bandage, which also means the areas where we have vision center, the patients who develop corneal ulcer is very, very low. And the people who need a corneal grafting because of these corneal ulcers also almost nil, I can say that, because once it is prevented, even when they develop, they are seen early by the doctor, so they are able to take care of it. And again, we are also able to deliver like a tertiary care. Now, once we diagnose a patient with a glaucoma, diabetic retinopathy, something, they also need continuity of care. Now, once after we diagnose, then the subsequent care we are able to also deliver it through the vision center and make and again, glaucoma, you need to continue to apply the medications regularly, which may not be available in a rural location like that. When we have a center like this, we are able to ensure continuity of treatment. In many ways, this is it's really useful. I think wherever all the eye care providers who are listening to this talk, probably you should consider putting these centers so that you are able to reach everybody who needs eye care. So, thank you.
Surely. Thank you so much, sir. Thank you so much, everybody, for participating in this session, and thank you, sir, for your insight on this eye care. And hopefully, we'll have another nice session with you again to elaborate more, and your extensive whatever you have done later on these things. We can have a session again for this. Thank you so much, everybody. Okay, good afternoon.
Thank you. Thank you very much for the opportunity.
Thanks a lot. Thanks a lot. Thank you.
Thank you so much, sir.
Yeah.
Have a nice day, sir. Take care, sir.
Yeah.
Thank you, sir.